Hi, I'm Ben Smith, a clinical research physiotherapist at the University Hospitals of Derby and Burton in partnership with the University of Nottingham. I'd like to start by thanking the organisers of the Forward Thinking Physio project for inviting me to talk about my research interests. The title of my talk is Musculoskeletal Pain, Challenging Existing Paradigms and Introducing New. I'm going to be talking about pain and exercise, specifically how pain fits into exercise prescription and how we may be able to use it to our advantage. The majority of what I'm going to discuss was produced in collaboration with other researchers, and so I'd like to thank and acknowledge all of them for their contribution and help. I'm going to start by setting the scene and describing my perspective on healthcare and physiotherapy for people with musculoskeletal pain. There's a lot of uncertainty in relation to treatment, particularly exercise prescription, but one thing that we're pretty certain of is the health benefits of exercise and physical activity, with the link between musculoskeletal pain and physical inactivity and chronic disease becoming increasingly understood. For example, we know that up to 75% of people with musculoskeletal pain will drastically reduce or stop their physical activity. We know that physical inactivity, for example, in the United Kingdom, costs the economy €10 billion a year and accounts for 1 in 6 deaths. We also know that people with musculoskeletal pain have a 17% increased risk of developing chronic disease, such as cardiovascular disease, cancer, diabetes and respiratory disease. And I often think about what will happen to a patient in front of me when I'm working clinically in 10 years or 20 years' time. Yes, my priority is to help them with their current pain experience, but how can I maximise lifestyle choices around physical activity and exercise? How can we reduce the future need for healthcare? How can we teach them to self-manage future musculoskeletal problems, any musculoskeletal problems? And can we encourage a healthy, pragmatic attitude to pain and activity? And I think by changing our mindset around pain and exercise, we might be able to achieve this. And really the conceptual framework for this is the relationship between population health and data and person-centred care, with physical activity being the link between the two. How does our individual person-centred care and treatment impact on population health? So the aims of this presentation are to go through and discuss how exercise and pain is looked at in clinical trials and trial guidelines, how clinicians currently view pain and exercise, the link between pain and the response to exercise, the role of pain in exercise, and any mechanisms and evidence behind the potential benefit of pain and exercise. So first, let's look at how exercise and pain is looked at in clinical trials and trial guidelines. And really one of the interesting things is that pain and exercise, I think it's become an elephant in the room. It's become a topic or perhaps a key variable of exercise prescription that's been historically ignored and overlooked. I think it's been ignored by researchers and feared by clinicians. So how does it fit into randomised controlled trials guidelines? Well, exercise therapy is a very generic term which can encompass a large variability in what is actually prescribed. And so the template for intervention and description and replication, the TIDIA checklist, was developed to address this barrier to research translation. Essentially, it was produced to create a checklist that researchers should adhere to when they're describing their exercise intervention. However, it wasn't specifically designed for exercise trials, and it doesn't cover the important exercise prescriptions. So Toiger and Battaglia outlined 13 items used to describe exercise, which provide a framework to standardise reporting of exercise interventions. Then later on, CERT was developed through a Delphi study, the Consensus on Exercise Reporting Template, and this was aimed to be an extension of the TIDIA guidelines. And essentially none of them mention pain, or rather they all ignore it. So up until now there's been no incentive for researchers to describe how much pain should be prescribed with their exercise intervention. And actually the only mention of pain in these reporting guidelines is with the CERT checklist, where exercise-related pain only exists as an adverse event. And they define an adverse event as an untoward occurrence, which may or may not be causally related to the trial or the intervention. So they frame pain purely as an adverse event, which I think automatically biases exercise towards pain-free exercises. I think it's also a concern because framing pain as an adverse event really ignores important matters of relevance about addressing patients' questions about exercise and pain. That's a topic I discuss a bit later on. So with no recommendation from reporting guidelines around pain and exercise, it may come as no surprise that this key variable is underreported in the trials themselves. So we conducted a systematic review back in 2017 looking at painful exercises compared with pain-free exercises. And only 7 randomised controlled trials met our inclusion criteria. There were some trials that did include pain in their exercise description, but for other reasons didn't match our inclusion criteria. And some trials have been published since we conducted our systematic review. So to my knowledge, there's only ever been 17 trials or studies ever published that include pain in their exercise description. And so as a result, clinicians have very little information on how to prescribe exercise and very little information with which to answer patients' questions in relation to pain and exercise. Okay, so how do clinicians currently view pain and exercise? Well, to my knowledge, we only have data from 2 studies that have looked at how physiotherapists prescribe exercise, particularly around or in relation to their belief and attitude to pain. So Chris Littlewood in 2012 conducted a survey of 110 UK physiotherapists. In his survey, he demonstrated that 44% of physiotherapists would encourage their patient to stop if an exercise was painful, with the remainder of the physiotherapists saying that they would encourage their patients to continue if the exercise was below only a certain level of pain, with a whole range of ideas given. I conducted a similar cross-sectional online questionnaire survey in 2017 looking at patellofemoral pain, which included 99 UK physiotherapists. And similarly, over half of the physiotherapists would not prescribe an exercise if it was painful, and the remainder qualifying their answer by completing an open text box. And the physiotherapists said that they would continue with exercise if the pain was below, again, a certain level of pain, with a whole range of ideas given, and it ranged from 1 out of 10 on a visual analog scale up to 6 out of 10. And some physiotherapists use words to describe it, so they would encourage their patient to continue with exercise only if the pain was moderate or acceptable or mild. And our patellofemoral pain survey also asked physiotherapists about physical activity, so sport and leisure activity, and similarly, an overwhelming belief with the physiotherapists included with this sample was that people should stop or curtail their physical activity due to pain. Given that there is very little information from trials on how to prescribe exercises, and very little information with which to answer patients' questions in relation to pain and exercise, it is no surprise to me that clinicians advise inconsistently. So from a public health point of view, would a consistent approach get better results? Now let's look at the link between pain and the response to exercise. Let's get a show of hands. Who here prefers quantitative data over qualitative data? 1, 2, 3. Okay, looks like everybody. Can you tell me why do you prefer quantitative data? This cartoon demonstrates well the powerful difference between quantitative research and qualitative research. If we ask patients what they think, we may better understand the problem and may better help them. So in 2017, I interviewed a sample of patients with patellofemoral pain to try to understand their lived experience of patellofemoral pain. I recruited patients from a physiotherapy waiting list. The mean age of participants were 30.6 years, ranging from 26 to 27. There were 3 male, 7 female, and the mean duration of symptoms was 78 months, and that ranged from 3 months up to 16 years. So a typical sample of patients with patellofemoral pain. We designed semi-structured interviews to explore the participants' experience of living with their knee pain, past healthcare management, interpretation of causation of their pain, their beliefs and attitude and behaviour in relation to their pain, and their expectations for the future. The participants offered a rich and detailed account of the impact and lived experience of patellofemoral pain. The first theme to emerge from the data, impact on self, and that described the participants' sense of loss in relation to their self and self-identity. And the further themes described how they dealt with that loss in a climate of uncertainty and how they understand and make decisions about their knee pain. I won't go through all the data, but I'll summarise some of the results that are relevant to this presentation. Impact on self. So self in its broader sense can be defined as one's individuality and process of making sense in the world around them. It is a cognitive structure that defines one's self and sense of worth. Self-identity, however, is the cognitive structure of internalised meaning and expectations associated with one's position and role within a social network. So loss of self and loss of self-identity were evident in the stories told, with an inability to continue with significant and meaningful activities. They described how their lives were socially and environmentally restricted. For example, I struggle at work, bending down to get to the bottom shelf and getting back up. I'd literally have to hold onto the table to pull myself up. I can't do it off just my knees. Several participants described the negative impact on patellofemoral pain on their mental well-being. And they also described loss of activities, and these participants described their activities as including walking, exercise, driving, holidays, time with family and friends, playing with their children, duties at work and kneeling. And these loss of activities directly affected the participants' role and position within their social network, often triggering feelings of loss of self-identity. For example, a number of participants explained how patellofemoral pain affected their work and made them question their career aspirations. I would say it makes me wonder if I can do my job anymore. Disruption to important and meaningful relationships was strong and commonly found within this patient sample, with judgmental attitudes from colleagues, friends or family, with subsequent feelings of low moods and feeling of premature aging. I've missed out on things over the years, spending time with friends, spending time with family and that kind of thing, because I've not been able to do it. They're saying that I'm a grandma. They say, yeah, if you were a horse, they'd put you down. Confusion and sense-making formed a central part in the lives of the participants. And this is described in our second theme. And expressly linked to the participants' confusion was the need to find a cause for their pain, and also a strong desire to pursue radiological imaging and feelings of not being taken fully seriously by the healthcare professionals when this was not forthcoming. Also, different to treatment approaches further compounded their confusion and mistrust. One participant discussed having different treatment approaches with different physiotherapists very succinctly by saying, well, it makes you wonder which one to believe. Because I'm like, well, okay, he's told me not to do anything until I'm pain free, because he doesn't want me to aggravate it. But then she said that it would probably be best to start putting an impact on it again. The patient went on to describe how they ended up with what I refer to as confusion paralysis. They didn't know what to do for the best, so they didn't do anything. The third theme, exercise and activity beliefs, describe how the participants identified specific beliefs regarding barriers to exercise and activity. And these were informed by factors relating to diagnosis uncertainty, cultural beliefs around pain, with fear avoidant behaviours, and an iatrogenic effect of healthcare. It's, are you making it worse? And that's the crux of it, really. If this is hurting, and they're talking about exercise, should I really be doing this? Or should I pack this in and do something else? It's the not knowing. And that cultural belief around pain. For example, for me, it's always been, if something hurt, it's because your body is telling you that you're going to do more harm or more injury. And that iatrogenic effect of healthcare. I've been told by my doctors before that I shouldn't run because it would jar my knee, and I shouldn't run or walk on uneven surfaces because it will wonk my knee from side to side. I find this quotation really rather interesting. They've been told they shouldn't run or walk on uneven surfaces. And should that be forever, for the rest of their life? Should they not be allowed to walk along the beach on holiday, go for a walk in the woods with the family or a dog? Should they not be able to run across the fields with their children or play in a park? An essential coping strategy for the participants in this study was the concept of rest and avoidance. Interestingly, one participant attending physiotherapy was asked what he thought the physiotherapist would say about recommending activity with them having pain. The physiotherapist would say, no, you shouldn't do it. You shouldn't remain active. And as I say, the central coping strategy was rest. This participant described, I try and sit down as much as I can. Also, there were low expectations of physiotherapy, with past physiotherapy failed treatments and poor expectations of the future. So, for example, the pain. It's definitely preying on my mind. Is it going to stop me from going into the police? Is it going to stop me doing the things I want to do later in life? It's preying on my mind. A participant was asked, have you got any expectations of what might happen when you walk in to see physio? I expect them to turn around and say physio can't help. When I'm going up the stairs and it hurts, it does concern me that it's going to be every day for the rest of my life, that I'm going to be struggling to walk upstairs. And then I think about getting old, and I think I'm going to end up in a stair lift, with a stair lift, and living downstairs. From a 26-year-old. So in summary from this small qualitative study, the loss of physical ability was profound and considerable and played a significant role in the participants' lives. There was low expectation for the future, low self-efficacy, which could be conceptualised as catastrophizing. There was cultural beliefs around pain. The patients characteristically attributed their pain to structure or anatomical problems. And this is the first study on patellofemoral pain to demonstrate an iatrogenic effect of healthcare, where the fear avoidance behaviour existed with clinicians. With the range of interventions and the inconsistent approach of physiotherapists adding to confusion of the participants. So the final summary may be that practice should be simplified with consistent key messages. Essentially, there's cultural beliefs around pain, with pain-related fear, an iatrogenic effect of healthcare, which limited exercise and physical activity in our participants and our patients. So I go back to that elephant in the room. Clearly, pain and exercise is an important question to our patients. They're telling us explicitly that it's linked to their pain-related fear, low physical activity, low expectation for the future, and their poor level of function. So although there's limited data, what does the research tell us? Let's go back to that systematic review that I did in 2017. So I'm now going to quickly summarise the 7 included papers. So the first paper was a study, a randomised control trial, looking at adults with lower back pain. The intervention that they prescribed was a high load lifting exercise where pain was acceptable up to 50 millimeters of VAS, as long as the pain subsided after each exercise set. And they measured at baseline 2 months and 12 months, and essentially both groups had significant improvement in their pain and disability levels, with no significant difference between groups. The second paper looked at adults with lateral shoulder pain. Their intervention was a shoulder exercise an exercise program where they recommended 5 out of 10 on an NRS scale for pain during the exercise, as long as the pain subsided by the next exercise session. They measured at baseline 3 months and 12 months. Both groups had significant improvements in all outcomes, with no significant between group difference. Although interestingly, the intervention group, only 24% went on to have shoulder surgery, a shoulder decompression, compared to 63% in the control group. The next paper, by Chris Littlewood, looked at adults with shoulder pain. It was a single exercise that required pain during the exercise, no pain score given as long as the pain was acceptable to the patient and as long as the pain subsided after the exercise. Outcomes were at baseline 3 months, 6 months and 12 months, and there was no statistical difference between the two groups, but both groups had significant improvements in all outcomes. The next paper, also adults with shoulder pain. The exercise intervention recommended up to 5 out of 10 on a visual analog scale, as long as the pain subsided by the following morning. They measured pain at baseline, 6 weeks and 12 weeks. Both groups had a significant improvement in all outcomes, with no statistical difference between groups. The next paper was Achilles pain. The patients were told with the intervention to expect pain, but avoid increasing daily pain or morning stiffness. They measured outcomes at baseline 3 months, 6 months, 9 months. Baseline 3 weeks, 6 weeks, 9 weeks, 12 weeks and 1 year. And both groups had significant improvements in the outcomes from baseline with no between group difference. The next paper, Michael Ratliff, looking at plantar fasciitis. The intervention was that patients were allowed to exercise with pain, no pain score given, as long as there was no post-exercise increase in pain. They measured outcomes at baseline, 1 month, 3 months, 6 months and 12 months. Both groups had significant improvements from baseline over time. At 3 months, there was significant difference in favour of the intervention, but at all other outcomes, 1 month, 3 months, and significantly at long-term 12 months, there was no between-group difference. So perhaps a short-term benefit in favour of the painful exercise, but in the long term, no difference. The next paper was adults with Achilles pain. They were told that they were allowed pain up to 5 out of 10, as long as the pain subsided by the following morning. They measured pain at baseline, 6 weeks, 3 months and 6 months. There was no significant difference between groups, but both groups had significant improvements in pain from baseline. So with regards to the parameters of pain in the exercise intervention, so the contextual factors, the advice that the patients were advised or told to adhere to, each trial gave something slightly different. The key difference being if the pain was allowed or if the pain was recommended, if a pain scale was used or not, and the time scale that the patients were advised that the pain should subside by. And the maximum was up to the next day, but it ranged from immediately to the next exercise session up to the next day. Essentially, clinically significant improvements in patient-reported outcome measures were reported across all interventions and control exercises at all time points, with no clear approach being superior to the other. Then I conducted a meta-analysis. We initially conducted a meta-analysis of the outcome pain, and we did it at short term, medium and long term. Here is the result for short term. So 6 trials with 385 participants reported post-treatment effect on pain. So combining the results, the trials demonstrated significant benefit of painful exercises compared to pain-free exercises at short term with a small effect size. Medium-term follow-up, the meta-analysis demonstrated significant benefit in favour of painful exercises compared to pain-free, with a medium effect size. And at long-term, the meta-analysis demonstrated no significant between-group difference of painful or pain-free exercises. We then conducted a sensitivity analysis by removing some of the trials with high dropouts and the trials where we extracted the pain data from other reported outcome measures, and we scored the quality of the evidence using grades, so the grading of recommendations, assessment, development and evaluations. So at short term, there was a small effect size in favour of painful exercises with a moderate quality of evidence. Medium term, there was no difference between painful or pain-free with a low quality of evidence. And really the main thing that we're interested in, perhaps at long term, so at 12 months and over, there was no difference between the two groups with a moderate quality of evidence. It doesn't seem to matter if the exercises are painful or pain-free, and importantly, how painful they are and for how long afterwards, with the caveat being that the maximum was up to a day of the included papers. So if it doesn't matter if the exercises are painful or not, maybe it's time to start thinking about things a bit differently. So now I'm going to have a look at the role of exercise in pain and mechanisms behind it and any evidence behind any potential benefit of painful exercises. So what else do we need to consider? Well, contemporary models of pain reconceptualise pain and put forward the concept that is based upon the premise that pain does not always provide a measure of the state of the tissue. Instead, pain is modulated by many factors, and the relationship between pain and tissue becomes less predictable the longer pain persists. Altered central processing, or central sensitization, has been shown to be present in many pain conditions and may be more common than previously thought, with the immune system playing an important role in the development and maintenance of pain sensitization. Furthermore, unhelpful thoughts of patients and clinicians towards pain, including the belief that pain will not get better and that movement will cause further tissue damage or worsening of the pain, are also important issues to remain mindful of. It's thought that these 3 mechanisms interact via the fear centre of the brain, called the amygdala, which shapes our response to pain-related memories and fear. And I'll go through these 3 mechanisms in a little bit more detail. So altered central processing or central sensitization. And it's a common phrase used in research and clinically. It typically means an increased responsiveness to nociceptive neurons to normal input. So for example, touch or heat. So the way that the nerves work in the central nervous system changes over time, meaning that pain is no longer directly related to the presence and intensity of harmful or unpleasant sensation. The important thing is that there's no real way of measuring central sensitization, but in research there are 4 substitute measurements that are thought to represent central sensitization: hyperalgesia, allodynia, temporal summation of pain, and diffuse noxious inhibitory control. So hyperalgesia, so that is an increase in pain sensitivity. So more specifically, it means an increased pain response to something that is normally painful. So for example, a pinprick It is normally a bit painful, but in the presence of hyperalgesia, a person would feel more pain than usual. So allodynia, by contrast, is having pain to a stimulus that is not normally painful. So for example, a hug. Temporal summation of pain is an increased level of pain felt with the repeated stimulus of the same intensity. So for example, if a patient has knee pain and they're performing an exercise that is painful, they may complain of increasing levels of pain the more repetitions of the same exercise they perform. And this could be attributed to temporal summation of pain. Diffuse noxious inhibitory control describes descending endogenous pain modulation systems, and that covers a few overlapping mechanisms that can alter and reduce pain perception. The two primary mechanisms of activation of the descending nociceptive inhibitory mechanisms the two primary mechanisms are the activation of descending nociceptive inhibitory mechanisms and the release of endogenous opioids. It's a bit complicated, but it is often described as pain inhibits pain. An impairment of this condition has been shown in long-standing pain conditions. So if I were to summarise all of this, I would say that people with persistent long-term musculoskeletal pain have changes in the way that their central nervous system processes pain. The immune system. So it is thought that the immune system may play a role in persistent pain states and may contribute to the development of hyperalgesia and allodynia that I mentioned on the previous slide. So the process by which the immune system is thought to influence long-term pain is through the alterations of function of what's called glial cells. So these are cells that normally sense the presence of damage that can be interpreted by the central nervous system. So they stop acting normally on the immune function and start to be capable of acting on spinal cord, or on the spinal cord as nociceptors. So they can contribute to the development and maintenance of central sensitization, particularly through a positive feedback loop. And then pain-related fear, also known as affective aspects of pain. And this refers to thoughts, feelings and attitudes. It can be viewed as an umbrella term encompassing a range of negative emotional states. For example, kinesiophobia, so fear of movement or the fear of physical movements, fear avoidance, negative thoughts towards movements and the fear of injury or pain, catastrophizing, exaggerated negative thoughts, low self-efficacy, so low confidence in coping with pain and completing tasks, anxiety, feeling of worry or nervousness, and depression or low mood. And we're starting to understand that pain-related fear not only reduces function and quality of life in patients with pain, but can actually alter people's pain, with an influence on central sensitization via various pain mechanisms, such as increasing nociceptive transmission via spinal gate mechanisms or via modulation of descending pathways. It's also thought that it might influence temporal summation, where increasing magnitude of spinal dorsal horn neuron activation can increase what's called glutamine sensitivity. If you want to read more about these mechanisms, any more detail, then I advise you to have a look at my blog. I've written a few blogs on this topic with lots of references for you to have a look at. I've also written an editorial published in the British Journal of Sports Medicine, again discussing this topic in a bit more detail with lots of references for you to get your teeth stuck into. That is essentially a cut down version of a chapter in my PhD, which can be accessed online via the University of Nottingham. I suppose the obvious next question is, so what? How can exercise help these mechanisms? How can exercise help altered central processing, the immune system, or affective aspects of pain? And in order to understand that, we need to understand and know a bit more about the role of the amygdala. So evidence from neuroimaging has demonstrated the role of the amygdala. So that's the area of the brain associated with fear and the response to fear, in pain-related fear, and in its potential overactivity as a facilitator of pain and central sensitization and the immune response. So for example, exercise may work by reducing pain through conditioned pain modulation. So the network of subcortical or cortical structures associated with conditioned pain modulation actually include the amygdala. So exercises could provide the painful conditioning stimulus needed to trigger the conditioned pain modulation response, but within a framework of reducing fear avoidance and reducing the fear response of the amygdala. And with regards to the immune function, it's well understood that regular exercise reduces the risk of developing age-related illnesses such as heart disease or diabetes, but we also know that regular exercise reduces susceptibility to viral and bacterial infections, with research suggesting that exercise somehow improves the overall immune function. So studies investigating brain and immune function during experimental periods of induced stress have reported an increased activity of the amygdala, with subsequent increases in inflammatory markers. So exercise is set within a framework of reducing fear avoidance and reducing fear response of the amygdala may also lead to desensitization of pain as a result of dampening down the immune system. Exercises could challenge people in pain to think differently about pain and movement, with exercises offering an opportunity for people to learn to tolerate movements and activities that they previously feared gradually. What else do we need to consider? Well, for example, this systematic review of self-management interventions for people with musculoskeletal pain included 16 studies and over 4,000 participants, and they found self-efficacy and depression were the strongest prognostic factors. So they were factors that used to predict whether an intervention would be beneficial or not. And they also showed that reducing pain catastrophizing and increasing physical activity were the strongest mediating factors. So that is, factors that may explain how different treatments work. So perhaps we can use exercises based on pain mechanisms, trying to address pain-related fears such as self-efficacy, catastrophizing thoughts, or fear of movements, rather than targeting any specific tissue structure. What about self-efficacy? So we've talked about self-efficacy a bit so far. Well, self-efficacy can be described as the ability to cope, your belief in your capabilities to successfully complete a task. So it's made up of a few domains. Response outcome is an important domain in self-efficacy. It is the belief that doing something will give you a desired effect. So for example, if a person is doing exercise, do they believe that that exercise is good for them? Will it help them? Efficacy expectation is the belief that someone can actually carry out an activity. So for example, with exercise, does a patient think they can actually complete the exercise? So is an exercise good for them? Can they complete it? And painful exercises may alter and challenge both the response outcome and efficacy expectation. And within this context, and the theory that I presented, with the hierarchical construction of painful exercises from less painful to more painful, from easier to harder, also means that the patient begins to expect that they can tolerate harder exercises without triggering the previous pain experience and exacerbation and pain flare-ups. It also begins to provide evidence to the patient that they are systematically approaching their clinical and personal goals, combined with specific verbal and social persuasion from the physiotherapist, again another domain of self-efficacy, that can further promote and reconceptualize pain specific to the participant and in their context, that can all modify the self-efficacy of that patient. So this schematic was adapted from Louis Gifford's 1998 paper, Pain, the Tissue and the Nervous System, a Conceptual Model, with permission from Elsevier. And it's been adapted to summarise how central pain processes, the immune system and affective aspects of pain could respond to exercise in a positive way. That through the delivery of exercise that reconceptualise pain as safe and non-threatening, facilitated by appropriate clinical support, could challenge past beliefs and experiences. It's also worth noting that painful exercises may result in greater loads and volume of exercises, but it does start to challenge the idea that exercise prescription should be based on strength and conditioning principles, focused on tissue pathology, or focused on tissue approach. It's also worth noting that the limitations in this concept that I'm presenting. Many of the concepts and mechanisms that I've discussed are only supported by preliminary data, and even the systematic review that I mentioned only shows a small difference in efficacy at short term. However, some of these concepts have been used to develop interventions, and I'd like to share some of the results from a feasibility study that I conducted on patellofemoral pain. So I conducted a feasibility study on 60 participants, where 30 participants received the intervention based on the approach that I've discussed. And it also included an embedded qualitative study to explore barriers and facilitators to the intervention and physical activity. I'm going to share briefly some of the findings. So as I mentioned earlier, qualitative data can be really powerful, particularly when used with quantitative data. We can use qualitative data to generate hypotheses and explore themes within a study that can then be used with inferential statistics on quantitative research, looking at efficacy and effectiveness testing on larger population samples. So we designed semi-structured interviews to explore the participants' experience of their response to treatment, with the delivery of an intervention described on these concepts, their belief and attitude to pain after the intervention, their belief and attitude to physical activity, treatment expectations, and protocol parameters. So the themes that emerged from the data were locus of control, belief and attitude to pain, treatment expectations and preference, engagement with the exercise. We also included an interview where components where we interviewed the physiotherapists, which I won't be discussing now, but that included how the physiotherapists developed their clinical development. So locus of control. So locus of control is the psychological construct about the degree people believe they have control over their actions and outcomes. So interestingly, patients within the intervention group, compared to usual physiotherapy, describe narratives that could be conceptualized as having a greater internal locus of control. So remember, we've asked them to do an exercise that is painful, based on the approach that I've discussed, around trying to reconceptualize their pain from being something to be fearful of to be something that should be approached as something that should be safe. So for example, this patient was asked, how did you feel about being in charge of that exercise? I think it was empowering in a way. Locus of control is also interrelated to the psychological construct of self-efficacy, which I've discussed quite a lot in this presentation. It relates to the power of thinking and achieving treatment outcomes. So remember, the exercise intervention is designed around trying to empower patients and answer their questions around pain and exercise. This patient described exercising, that sense of just how much progress you've made. A week ago you did 20, and now you did 30 or 40. When I hit the target, I then thought, oh, I can actually do a few more, and it is comfortable to do. We also asked patients to describe how they engage with the exercise. And they talked about pain education, the idea around dosing and self-titration of the exercise, the idea of it being painful and simple. And I think I'm going to start to summarise my talk now, and I think this quotation perhaps is a great way to end the talk. A patient described that it's that changing mindset that says, I can still do these things. I'm not shying away from getting stuck in and being active. The patients also described how they thought these exercises that were painful actually were quite simple. If the problem starts again, it's no real problem just to start. So I'm going to conclude now by summarising. So I've talked about how pain is the elephant in the room. It's not reported in the literature. It's not covered in guidelines. Clinicians largely fear it, and there's a large variability in practice. Patients report high levels of pain-related fear and report that pain and exercise is an important question. and it's often overlooked in their experience, and that pain and exercises may actually be helpful. It may help with dosage of exercise, and it may address those pain-related fear and activity levels. Essentially, pain need not be a barrier to exercise and physical activity. And my perspective is, as a clinician, we can guide the patient on a journey to reconceptualise pain as safe and non-threatening, and away from the model that pain equates harm or damage. And to do that, we need to confront pain through our exercises. If you have any questions, please feel free to send me an email, or send me a tweet, or access me via Twitter. And thanks very much for listening. I hope you found it useful.